Good morning, everybody. We'll get started in just a couple of minutes. Thanks for being here. If you would just introduce yourself and your affiliation in the chat, that'd be great. All right. Good morning, everybody. I think 2 minutes is my usual grace period for a late start. Thank you all for being here this morning. I'm Vincent Adjety. I'm the CEO of Mental Health Colorado and continue to direct the Equitas project, which is our focus on disentangling mental health and criminal justice. And if you're rejoining us for this monthly meeting of reports and updates from Colorado partners who are working to disentangle mental health and criminal justice, welcome. And if you're here for the first time, welcome. And that's what we're doing. Is this is a group of variable size and composition, and we will do our best to keep this group going and keep it growing over months to come. The idea is that we have brief presentations from partners doing key work in disentanglement, and then a brief opportunity for some questions and answers and discussion. And then we wrap things up by 12:15 so that this is not a gigantic chunk out of your day. So with that, I'm going to go ahead and introduce our presenters for today, and we can have some time to share other updates at the end of today's meeting. So thank you so much. It's my great pleasure to introduce, I believe, Amanda Myers and Kathryn Davis from Office of Behavioral Health's Forensic Support Team to share what you're here to share with us today.
Thank you, Vincent, and thank you for the invitation. So my name is Amanda Myers. I am the director of the Forensic Support Team, and Kathryn Davis actually joins us from the Outpatient Restoration Team, and we're gonna kind of explain to you how all of this kind of connects. So really through Senate Bill 19223, the Office of Behavioral Health was allocated 20 staff positions to serve as the Forensic Support Team. So we are a brand new, actually not brand new. Today is our 2-year anniversary. 2 years of being a team, but I don't know why. And maybe it should feel longer, but it doesn't feel longer. It's been 2 years. This team consists of we have 16 forensic navigators who are located within all 55 jails across the state and in all 22 judicial districts. This team includes 2 program coordinators who are licensed clinicians. The program coordinators provide supervision to the forensic navigators and ensure a consistent coordination of competency restoration services. The forensic support team serves as the primary point of contact for OBH competency services and stakeholders. So what do the navigators do? Who are they assigned to? And what the heck is this team all about? So forensic navigators are automatically assigned to individuals who are waiting in jail for a competency evaluation, who are waiting in jail for admission to inpatient restoration, individuals participating in inpatient restoration, and individuals returning from inpatient restoration, waiting in the jail to be reviewed by the court. So what do? Forensic navigators meet face-to-face with competency-involved individuals and multidisciplinary teams within all of the jails. This includes jail-based behavioral health services, also known as JBBS. This includes court liaisons, jail administration, jail medical staff, all of those people that are involved in the coordination of care. Through client interaction, client observation, and by gathering collateral information, the FST assists the state mental health institutes and other inpatient restoration sites with prioritizing and triaging admissions to inpatient restoration sites. So what does this mean? So this means that when we have people that are waiting in the jail to go to inpatient restoration, a judge has said, I agree, you are incompetent to proceed. And I think that you probably need to do inpatient versus outpatient restoration, and the person is waiting in jail. We kind of take a big look statewide and we say, how many highly acute individuals do we have that need inpatient restoration? And then from there, we look at each jail and we say, what resources do these highly acute individuals have or not have? And then we bring that information to the hospital and we say, hey, these people, for various different reasons, need to move a little bit quicker than everybody else. So the other thing they're involved in is they identify low acuity clients who are maybe medication compliant, maybe in general population, who may be better suited for outpatient restoration services. In these instances, the FST makes referrals to and collaborates with programs, again, such as Bridges Court Liaisons, jail transition teams, Momentum, Colorado Coalition for the Homeless, community mental health centers, and other stakeholders to build community transition plans and inform the court of these plans. Finally, forensic navigators ensure care coordination for individuals returning from inpatient restoration to the jail. So they ensure that the jail and the JBBS teams or jail medical or jail mental health teams are aware and equipped to provide any medication that was prescribed during their time in inpatient restoration. They also make sure that the court knows that this person is about to return to the jail. And that way, if we have a court date that's set out 60 or 90 days, we ask the judge to please move that court date up so that the person can be seen a little bit quicker. If a forensic client is unlikely to be restored to competency in the foreseeable future and the court dismisses the charges, forensic navigators work with community case managers and other jail staff to ensure that these clients have referrals, resources, and services that will support their successful reentry back into the community. So I talked a little bit about outpatient restoration for the population, for our general, our population of low acuity clients. And so while Kathryn has people that may have never been in the jail and may have never transitioned, we also pass our people that are transitioning, our individuals that are incarcerated into the community, we pass those off to Kathryn. So I'm going to let Kathryn talk about what services and how she gets our clients connected once they transition to outpatient restoration.
Thanks, Amanda, and thank you, Vincent, for inviting us. We really appreciate being able to talk about what we do. Again, my name is Kathryn Davis. I'm the program director for the Outpatient Restoration Program. And for those of you who may not be familiar with outpatient restoration, we've been in existence since March of 2018. We were put into place to provide outpatient-based restoration education and referral to services for individuals who were found incompetent to proceed, but who the court believed could get their services in the community. And to give you an idea of what the need for this particular service is, when we first started, we were projected to see 268 people in our first fiscal year. And we ended up seeing 689. And we continue to have high numbers of individuals who are able to get their services in the community being transitioned either by Amanda's team into the community or the courts having the trust in our program to make sure that these individuals are in outpatient services from the very beginning. So outpatient restoration services, which is a statewide program, services are offered in all judicial districts in every county of the state. We serve adults and juveniles in competency restoration. The restoration process has 3 parts to it. First, we provide restoration education, which is factual legal knowledge as well as rational understanding of the legal system. And so that's the psychoeducational piece of competency restoration. We also have providers who then will refer either in-house, if they're a community behavioral health center or agency that has services in-house, or within the community, to services that will address the barriers to competency for that individual. So if the barriers, for example, are a mental illness, then the barriers that are addressed are through therapy, medication management, things of that sort. Additionally, in the third prong of this, which isn't kind of the official piece, but it's the non-official third leg of the stool, is that we also try to get individuals connected to resources and services and supports in their own community so that they can be successful long-term in their community. And these are things such as, housing or social supports or other resources that they may need with regards to maybe medical issues or anything else that will help facilitate them being successful long-term. Because what we really want to focus on, not just fulfilling the court order in the moment, but the outpatient restoration program and all of our partners, we really want to focus on making sure people have what they need in the community so that it serves them well beyond competency. So if somebody's case is dismissed, or if they're found competent, they continue with their case and resolve it. We want to make sure that they're in their community and connected in a meaningful way. So we do partner with a lot of community partners, specifically with regards to our providers. We partner with all 17 mental health centers throughout Colorado. We also partner with over 30 private providers and private agencies who provide these services as well throughout Colorado to fill any gaps in capacity that we need. Currently, we have no wait list for services. And again, we do serve both adults and juveniles in this program. We provide education, referral, and those resources. And really the goal is to make sure that individuals who are ordered into outpatient restoration not only get the services that they need, but to keep them out of the criminal justice system by making sure they're well connected within their communities. Would you have anything to add, Amanda or Jagriti?
I think the biggest piece, if we could back up for just a moment, kind of setting the stage of how all of this works. I know we've got a variety of folks in this audience here today, but I want to spend a second just clarifying what the issue of competency really is, because that's an area that we tend to get a lot of questions about. And it really is a legal construct that allows basically the court system to be sure that the individual understands what their legal proceeding is all about. So I think a lot of times what we're asked is, well, why is this person still is appearing to have a lot of symptoms? How are we at a place where this person has been opined restored at this point? So I think there's a large difference here between what we would say is someone is, I guess, in a stable place or is no longer experiencing any mental illness symptoms versus they are understanding what needs to happen to proceed with their criminal case. So I think that's the biggest piece. And then next time, Amanda Edwards, who I see is on this call as well, that's the court services team, and she's the director of that team. She'll be really presenting some of the details related to what the competency evaluation process looks like, and how we get to the place where there's recommendations made for restoration services. So I just wanted to pause there for a second and add that additional context.
Thank you, Jagruti. Vincent, if you'd like, can we open it up for questions?
Absolutely. Thank you. Thank you, all three of you. And yes, any questions from anybody?
I think one of the things that we should certainly highlight also, and I see Dr. Neil Gowan-Smith is on the call as well. He is our court-appointed special master to address the legal situation that the Department of Human Services has been engaged in for many, many years, and is currently in the process of addressing through a consent decree. That consent decree, and then followed by Senate Bill 223 that Amanda Myers talked about, was basically the largest overhaul of the competency system since, I think, in decades. So there is various components that were added related to updating the process and procedures related to how individuals are placed on the wait list for inpatient services. We have, I would say, 4 settings where restoration occurs. We have inpatient and outpatient. Outpatient services, as Kathryn described a little bit ago, and then inpatient services, most of those do occur at the Colorado Mental Health Institute in Pueblo. And then we have additional contracts with the jail-based restoration program, also known as RISE. We have 2 locations, one at Arapahoe County Jail that is currently at 80 beds, and then a second one at Boulder County Jail, which is 18 beds. That is also considered an inpatient setting. And then we have private contracts with private hospitals, which is Peakview and Denver Health Hospitals. And then lastly, we have a smaller program that just started up at the Denver County Jail, and that is also considered to be an inpatient setting, but is not part of the RISE program per se, because it's through a different vendor. Denver Health is actually a contractor at that facility. And Neil has his hand raised, so I'll let him speak for a second.
Thanks, Jagruti. And thanks for pulling this thing together, Vince and others who are involved with that. It's such a great series. Apologies for being off camera there for a bit, but I was trying to squeeze in some lunch. So nobody wants to watch me eat. I don't have a question, but I do have a quick follow-up to what Jagruti laid out. So essentially, for those of you that aren't living in the forensic mental health world, Jagruti did a nice job of outlining what competency is. It's essentially making sure that a person understands what's going on at court when they are charged with a criminal offense, and if mental illness is a major barrier to them understanding what's going on, then the court can't proceed. Right? That's not constitutional. You can't prosecute somebody who doesn't understand what's going on or what the charges are against them. And so when that is true, the person is found incompetent to proceed, then generally they're ordered to restoration. And historically, that's always happened at the state hospital. That's kind of national model, but most places around the country, if a person is found incompetent to proceed with their trial or their hearing, they're ordered to restoration at an inpatient facility. And that's sort of how Colorado operated since the dawn of competency statutes. But the problem is, over time, more and more people are being found incompetent than there are beds at the state hospitals. And so then what you have is a wait list. People start to wait for their bed to open at the state hospital. And where do they wait? They generally have been waiting in county jails. And as we know, county jails are not great places for serious mental health problems. And so over time, you see more and more people waiting and waiting and waiting, and they're waiting longer and longer. And so we have to have a new kind of approach to this. And Jagruti, Amanda, and Kathryn have done a great job of just kind of explaining some of the different ways that the department has responded to this crisis. It's a crisis that's happening across the country. And Colorado has answered the bell well. Outpatient restoration, taking some of those people out of jails who are on the wait list and putting them into restoration where they can be safely managed in the community and move on with their mental health treatment and their competency goals. Amanda's team does a remarkable job of monitoring everybody who is on that wait list in jails every week to make sure that they're not decompensating and making sure that other options are being considered. And so what we have is a much more nimble and sophisticated system in Colorado than we ever had before. Before, it was a system in which, sort of like the deli counter or the DMV, you go in, you take your number and you wait in line, and it doesn't matter what your issue is or how sick you are. And certainly we know that hospitals don't work that way for physical problems. If you have an urgent medical problem, you go to the emergency room and you can be admitted ahead of somebody who might have been waiting there a little longer if your condition is more urgent or more life-threatening. And it's the same thing now for competency. And so we've got a pretty nimble and sophisticated system that really does a good job of looking at both clinical need and criminal justice involvement, public safety concerns, and different options for each of those people who are in the competency system. And we see progress on all the different metrics. And it's a real credit to Jagruti and her team, Amanda and Kathryn and others on the team that are really focused day in and day out on this population and trying to get them into the services that they need. I'll turn it over to whoever wants to answer those questions. Those good questions are in the chat. But I will say, just as a spoiler alert, it's working. All these programs are working pretty well. Recidivism is low, and we're getting the sickest people into the hospital the quickest. There's a lot of work to be done to get people in within a timely manner across the continuum, but I am impressed with the way that the department has responded to those who have the most urgent clinical needs. So just want to provide that context, and I'm not sure who's going to respond to those questions or what the process is going forward. Essentially, who's going to start talking after I shut up. But pleasure to be here, and good job. Congrats to OBH for the good work so far.
Indeed. Thank you, Neil, for additional clarification and for being with us and for answering the first of those questions about the recidivism of folks engaged in these services. Another one of the questions in the chat is, what sort of symptoms do you most commonly see as preventing competency?
I can speak from the outpatient restoration perspective. We see some pretty severe mental illness, psychotic disorders, delusional disorders, bipolar. For many of our individuals, it's an intellectual developmental disability, either primarily or secondarily. So there's a range of symptoms that we see, but those are the most common that we see in the program.
Thank you. And what level of offenses are individuals being evaluated or in need of restoration typically looking at?
I would say all levels of offenses, competency can be raised. Absolutely. In outpatient, we typically see misdemeanors and low-level felonies, but we have seen higher level offenses in special circumstances be in outpatient restoration. Typically, the higher level offenses usually stay in an in-custody setting. If you want to add anything, Amanda, I'd welcome that from your perspective.
No, I think the same thing.
Can I add a little context? I can't stop talking.
No, do not stop. Go right ahead.
Well, so the information is exactly right. You see a wide range of offenses. What we're seeing Historically, what we've seen for competency cases is more serious charges. What we're seeing more recently in the past 5 to 10 years is more and more misdemeanors being put into the competency system. So people that, you might see on the 16th Street Mall if you live in Denver, or Civic Center Park, people who are charged with much less serious offenses, kind of quality of life transgressions coming before the criminal court for charges related to theft or drug use or disorderly conduct and those sorts of things. Cases that we didn't used to see in the competency court are now a pretty big chunk of business for the department. And it requires a slightly different approach, right? Not only does it exponentially increase the number of cases and defendants that the department has to manage for competency reasons, but sometimes the clinical needs for that population are stronger or higher or more intense for the misdemeanor population than you might see for more serious felony offenders. Those people with lower level charges are often sicker, and that's what's contributing to their criminal offense, right? And so it requires a different approach for the department to manage those clinical needs in a way that might have been different for the historically felony population.
Thank you. Another question is, are people with traumatic brain injury accepted into the outpatient program? And is it difficult to find appropriate housing for people with other co-occurring issues like IDD, TBI, SMI?
Well, I'll answer the first part of that, and then I'll let Amanda answer the second part since she's more involved in the housing piece. But TBI, absolutely. We have many of our clients who have a TBI diagnosis. We partner with the Brain Injury Alliance, which is a wonderful, wonderful resource. They've done training for our providers and do ongoing training for our providers, and so that they are aware and can identify TBI and get appropriate services in place for them. But yes, we do. Absolutely. Amanda, do you want to speak a little bit about housing?
Sure. Housing, as you all probably deal with at the intersections of behavioral health and criminal justice, is kind of a pretty significant ongoing barrier. For example, I know that we have the Colorado Coalition for the Homeless housing that we use, restoration housing, and those are for individuals who we just spoke about that might be doing fairly well in the jail, maybe taking their medication at some rate of compliance, and might be eligible for a housing unit through the coalition, where they can receive assertive community treatment and kind of some wraparound services. And then we have some other populations that are in need of host homes, that are in need of assisted living. They're in need of skilled nursing, and it continues. The big barrier continues to be that individuals who are incarcerated do not have their Medicare, and Medicaid gets paused and then has to be put back on, and that process really hinders our ability to transition individuals into the community. So even though somebody might be released from jail and their Medicaid or Medicare is unsuspended, most assisted living centers and different sites are not going to accept those individuals until these individuals can have a pre-authorization. And so oftentimes we're dealing with trying to find people with TBIs, significant TBIs, dementia, all of those other things. You can't really just put them into the community for 30 days while a nursing home or skilled nursing gets a pre-authorization. So that's probably our biggest housing barrier at the moment, with the memory disorders and TBI and other physical issues.
Yeah, and I would add that, we utilize programs like Momentum to try to help with that benefits attainment and for funding to, if nothing else, some temporary housing for individuals, but there are still some significant gaps in housing throughout the state.
Carla's asking, what is the average length of time for competency restoration?
I can speak to the outpatient modality, and currently, I mean, we do a little bit of this, but we run between about, I would say on average around 150 days or so, which is a really good rate for resolution of those cases.
For inpatient services, the average length of restoration is 120 days, and that has varied significantly over the last year due to some of the pandemic-related discharge barriers. We've had various things go on related to jails, needing additional testing and things like that. So that's been adding some time to discharge. And then I think a lot of you are aware that ACFs, the assisted care facilities, had a lot of restrictions around admissions as well. So that in general, our restoration rate is about 120 days for inpatient.
And just to add a little more context, the length of time is an important marker, as is the restoration rate. And restoration rates in Colorado are for people that are inpatient are equivalent to those around the country. You know, north of 80% of people who are ordered inpatient restoration are eventually restored. For outpatient restoration, it's also equivalent to other places around the country, but the rate of true restoration is a little bit lower. I'm sure Kathryn can speak to some of the other ways that success or progress is monitored or measured in the outpatient program, because sometimes people are placed in outpatient restoration when they have charges that are can be minor, and those have time frames associated with how long a person can be restored. So sometimes a person is eventually timed out of the restoration process before they're formally restored, but they've done everything that they're supposed to do and met all the court ordered requirements. In the meantime, just their time kind of maxes out. So the restoration rate in the outpatient system is a little bit fuzzier of a number to know what to do with.
Absolutely. We consider a case being dismissed as a positive outcome, being that either, you know, like Neil says, the time frame has expired, but more frequently it's that the court sees that the person is engaging in services and is willing to consider that dismissal. So again, that's why we work so hard to make sure people are getting connected to services as quickly as possible, because if we do have that opportunity for their case to be dismissed, we want them to be connected to services at that time.
Thank you. And so let's see some more questions in here. Sonia asks, is anyone collecting data on the number of clients who have Medicare and have used up their lifetime limit of 190 days of inpatient psychiatric treatment?
That's a great question. It's definitely something that we face continually, trying to arrange for how we can get someone really into the level of care that they need. I think part of the conundrum that we've frequently faced with trying to get someone into inpatient psychiatric services through the civil system is their pending legal situation. So it's one of those unfortunate chicken and egg types of situations where the court or the hospitals are not willing to accept someone due to their legal charges, and the court is not willing to dismiss the charges until we actually have an acceptance into a psychiatric facility. So I think some of our navigators have tried to address that. I know our RISE program particularly has been working on various efforts where someone really does need to be in the civil system versus the forensic system for restoration. I know that doesn't specifically answer your question, but so specifically to your question, we're not collecting that data, but it's definitely an issue that we're encountering.
Thank you. And Carla asks, do you know what percentage of clients are experiencing homelessness at the time of program enrollment, whether inpatient or outpatient?
I can speak to our inpatient population. About 46% of incarcerated competency individuals were homeless. About 35% reported living with a friend or relative. 13% reported living on their own. 2% previously resided in assisted living, and then less than 1% resided in a host home or some type of supportive environment. About 2.3% were homeless with shelter, so kind of maybe living in an unstable environment, so on a friend's couch or something like that. That's what I have for that. Don't know as far as outpatient goes, but that's inpatient.
We don't have that data for outpatient at this time.
Thank you. And Troy, if you'd like to speak up and share, you had a comment? And if not, that's okay.
Oh, hi. Well, I just put in there for my point of view. I work with Kathryn, well, under folks underneath her to provide outpatient restoration. And just my personal experience, I do have some clients with TBI or other physical health concerns that affect their memory abilities. And so that's a big one to get over, because you know, you're basically teaching them a class. Do you remember what these people do in the court? Do you know the difference between the pleas? Do you know all your basic legal stuff you go through? I find it more difficult to work, very difficult to work with folks that have the memory issues. Just in general, I have a woman with a stroke and another with a TBI, and their memory is not good. While they're in their class talking about something, they get it pretty good. Then, you know, a week or two later, their memory issues take hold and they do not have good recall. So lots of repetitive stuff, but if they literally have a physical issue that causes them to have memory difficulties, that's a really persistent barrier. In my opinion, I'm fairly new at it, but that's just kind of a one-person viewpoint on some of my clients and what's hardest to work with.
Great, thank you. No, I appreciate the perspective.
Sure, thank you.
Other questions? I was speaking with a judge earlier about what seems to be the bind for public defenders, who are, as I understand it, often the ones who raise the question of competency for their clients, and recognize that when somebody is facing relatively minor charges, that not raising competency would serve the normal defender's ends of getting somebody out at liberty more promptly, but raising competency is their ethical obligation, even if it means longer term embroilment in the system. So I would just, that sort of interesting bind that public defenders are in suggests to me as one of the issues being that the justice system is the pathway to accessing care, which is otherwise not so accessible perhaps in the community. And that's why they are in that spot. But any commentary or observations or insights into that conflict for defenders, I'd be curious to hear your thoughts.
Yeah, I think that's definitely, you know, some of what we're seeing with considering the fact that the level of acuity of individuals that are ending up on our wait list. What we have is known as the triage system, which basically differentiates someone who meets 2765 criteria, meaning the need for immediate hospitalization. And at any given time, about 2% of the wait list is individuals that meet that level of criteria. And then the rest of the individuals, I think over time, as we look at our RISE program particularly, so I'm speaking from that perspective particularly, we're finding it's more difficult to place those individuals on the wait list into that program, because the main difference between the RISE program and the hospital settings that we have, so both at SimHip as well as Peakview and Denver Health, is when you have someone that is very acute, is in need of medications or involuntary medications, those are not the types of individuals that we can take into the RISE program. At the start, before the pandemic became an issue, that was really a thing that we were facing largely with having open beds at that RISE program, because the individuals on the wait list were not appropriate for that setting. So I think I'm answering this question from that angle, that we're definitely seeing more acute individuals that really wouldn't potentially be in the system if they would have received their services out of the safety net system.
Right.
Please.
It also speaks to the good work that that Mental Health Colorado is doing, and the efforts there to try and support diversion programs and other civil kind of programs and capacity around the state. What we have in Colorado is a lot of people who are sick, who need help, and often when they don't get that help, eventually they run into the arms of a police officer, and then that whole system gets kind of geared up, and that system has got just a few options to it. And once competency is raised, it's going down that path. And so what's really helpful is when we have additional options and additional mental health resources to get people from ever entering the criminal justice system in the first place. And events and others at MHC and other places are always looking for innovative ways to do diversion and try to promote civil resources and getting people into the mental health care that they need, rather than kind of waiting or expecting or assuming that the forensic system can do it.
Thank you, Neil. All right, so I've promised to keep these meetings short and sweet, and it's almost 12:15. I just wanted to share a couple of quick announcements with you, but first, thank you so much, Amanda and Kathryn and Jagrudi and Neil, for joining us today and sharing your thoughts and experience. I really appreciate it, and I know the others on the call do as well, and thank you all for joining us. So just a few things. So as many of you know, Colorado has a pretty substantial amount of funding coming in through the American Rescue Plan Act as COVID response. We've got, as House Speaker Garnett put it, a once in a generation opportunity with an infusion of $450 million to be applied for transformation of behavioral health in the state. And the work of the legislative task force to make recommendations about how to invest those funds has just begun this week. There will be a survey going out, kind of Google Doc survey, just seeking general input and suggestions from the community at large. And so your thoughts in response to that survey would be helpful. All of the proceedings of the task force and the subpanel for the task force are going to be as public and transparent as technology can make them. There's a dedicated website for the task force, which I can send along in a follow-up email, but I do encourage you to follow the conversation, and we may be reaching out for some presentation at some point or another, if that makes sense for the work that's going on. Another thing to mention, if you're not already aware, Mental Health Colorado and OBH have been co-hosting a series of emergency mental health stakeholder meetings to examine M1 holds and try and come up with some recommendations about policy fixes And that process is ongoing. Those meetings take place every 2 weeks. You'd also be welcome to join those open meetings. And just shoot me an email if you're interested, and I can make sure you get a invitation. I've got a document I'll share out with you. It's the 2021 Prosecutors Framework for Behavioral Health. And this is a product of something like 35 different prosecutors' offices around the country that we've been convening to share their diversion work. And so the idea behind this document is it just gives a kind of starting place for prosecutors who are not already engaged in diversion work to start thinking their way into that kind of practice, as well as a whole network of resources in terms of other prosecutors who'd be happy to provide guidance. On that end, we're also going to host a virtual National Prosecutors Summit in November to promote that notion of prosecutor-led diversion. And what else? Next month, Jagruti, you'll be back with us, as I believe, for sharing some more of the work that you do.
Yes, that's right. We're going to be back with Amanda Edwards and the court services team with their perspective on evaluations.
Great. Thank you so much. Any other updates, quick updates anybody else wants to share before we wrap it up? Hearing none. Well, thank you so much. It's 12:17. Sorry, I've kept you 2 minutes too long. Have a great day. Thank you so much for the great work that you're doing and for your thoughtfulness today. Take care.